Hello, I'm Melina Davis, and I'm the CEO and EVP of the Medical Society of Virginia, and I'm your host today on the Joymed podcast, and I'm thrilled to have a really esteemed guest today, Dr. Saul Weiner, who's a doctor and board-certified internist and pediatrician with practice, leadership, and research experience in a variety of healthcare settings. He served as a residency program director, an academic division head, a clinic director, and a health services investigator. Dr. Weiner is a former generalist physician faculty scholar of the Robert Wood Johnson Foundation, and he's also served as a principal or co-investigator on studies funded by the Robert Wood Johnson Foundation, the National Institute of Health, the National Science Foundation, and the Veterans Administration. He's currently professor of medicine, pediatrics, and medical education at the University of Illinois at Chicago. And importantly, he's written 2 books, including Listening for What Matters and On Becoming a Healer. And I couldn't be happier to have you with us today, Saul. Thanks for joining us.
Thank you. I'm so pleased to be here.
Tell me about what inspired you to write your 2 books. Specifically, I'm really interested on becoming a healer, but why become an author and what inspired you?
Sure. Well, it started with a more academic perspective, and then it became more personal. So the academic part of it is that I got interested in how we as physicians often become what I've come to call efficient task completers, where we're sitting in an office, interacting with a computer more than with a patient. And,
Yes.
we're asking the patient these typical questions like, when was your last mammogram? Have you had a flu shot? And so forth, typing in stuff, and then moving on from there. And often in that process, we sort of forget about the life of the person we're with. And we often
Yes.
fail to appreciate that that person is dealing with a whole set of issues that might be actually directly relevant to planning their care. It could be anything from they can't afford a treatment plan, to they don't have adequate caregiver support, to they've lost, they may have a new job or have competing responsibilities. The list goes on and on. Maybe they've lost trust in the healthcare system. And I came to think of all of those as what I call contextual factors. It's part of the life context of the patient. And many years ago, I partnered with a cognitive psychologist named Alan Schwartz, and we decided this is something we wanted to study. We wanted to study this as a quality of care issue. To what extent do we as physicians succeed or fail at picking up on these clues that patients are struggling with life issues that are directly relevant to planning their care? And if we're missing those contextual factors, to what extent is that resulting in a care plan that may look good on paper, but is going to be impractical? The patient won't be able to execute it because of any of these contextual issues, whether, as I said, it's something more in their head, like a trust issue or an emotional state, or whether it's something very pragmatic, like they don't have transportation or they don't have the ability to afford something. So that was sort of my life's work in the sense of an academic perspective. And at the same time, and that led ultimately to writing Listening for What Matters and publishing a lot of papers and through a number of studies that you mentioned grants for. But then after I had been doing that for a while, I started to realize that there was also a personal dimension to this, which is that there's something about the way in which we're being trained as physicians, and I certainly went through this process, that is leaving us in this impoverished state, as I see it, where we become so narrowly focused on just getting our tasks completed that we're no longer seeing this context in our patients, that there's something weirdly abnormal about it, even though it's become so normalized. And I think when people go to the doctor now, they sort of almost expect that their doctor is going to be going boom, boom, boom through a bunch of stuff and maybe not seeing them as a person. And that is, that's an indictment of the culture in which we're trained. And when I went through medical school, I had a really tough time. I'm very open about my learning disability, and when I was applying to medical school, I already knew I wanted to be a doctor, but getting through all those brutal multiple choice tests and all that pre-med stuff was really, really tough for me. And so that was really how I started to think about why I wanted to write on becoming a healer.
I want to go back to this point about you're the efficient taskmaster in there, getting it all completed and done. So much of what we as people do to communicate is visual, right? And how we pick up on what somebody actually means or what they're struggling with is visual clues. And I find that really interesting that you started to question about were you missing things from the context through interpretation. I love that because we know that that's important to look at people.
Yeah, and I think I often it's only half a joke, but I often say now that it's the doctor-computer relationship and the patient has become the data source when it's supposed to be, of course, the other way around. But
Yeah.
I do think that's a lot of what we hear. In my research, we
Yes.
audio record doctor-patient encounters. We've now audio recorded over 10,000 of them. And I have a team that listens to these. And so often what we're hearing is that the doctor seems to be very focused on the computer and the patient is almost on the periphery.
Yeah. Yeah. And there's a dehumanizing element involved for both parties and looking at the computer as the interface versus at one another.
Yeah, absolutely.
I know you write about how important engagement is in the experience. Talk about that and how this engagement occurs.
Yeah. So I think of engagement as just two people sitting down together on a level playing field with a sense of shared humanity. In this case, a doctor and a patient working through some problems together. In this case, it's going to be whatever it is the patient's come to the doctor with. And it's a particular way of thinking about that relationship. It's not the doctor with a white coat. It's not the doctor sitting, on a higher plane thinking that they're the expert. Of course, they have expert knowledge about
Sure.
the technique of meta, but the patient is the expert in terms of their life. And so they're just sitting together in a very genuine way, and there's a connection that's being formed. When I say engagement, I sort of mean like that sense you have when you're talking to somebody and you're on the same wavelength.
Yes.
That's the
Yes.
model of engagement.
It's interesting you use the term emotional engagement too, which I find personally very compelling. I do a lot of work with organizations about how emotional engagement has actually left business and that is exactly what we want to have happen with our brands. We want consumers to attach to our brands emotionally. We want people to care about the mission or what we're trying to give them in their life, but yet we've created processes and interactions that are devoid of emotion. But it's so powerful to be emotionally engaged. In medicine, I've never heard anybody talk about this.
Yeah, I mean, I think that there is something very right about engaging with people emotionally when it's for the benefit of their well-being and health in a healthcare situation where you're their doctor and they're their patient. I have a much more maybe cynical is the wrong word here, but yeah, I would say cynical view of the way in which emotion is used to get people to buy stuff. So I certainly think that in the marketplace,
Right?
marketers go out of their way to try to use emotion to get people to buy stuff, which I find
Yes.
pernicious. But in the
Right.
context of a doctor-patient relationship where that engagement is entirely for the benefit of the person, you're meeting them where they are and you're there for one sole purpose, which is to be helpful to them in whatever way you can. That's where I think engagement is is right.
Well, what's different, and I think you've hit on it here, is engagement is actually between humans. It's between the people. And emotional engagement to evoke emotional exchange and understanding is very human and very important and very lifting. Emotional manipulation, that's
Yes,
another thing, right?
exactly. Yeah,
Yeah.
yeah.
And so emotional engagement, do we at all address this in medical school training today? And why not, and what would you do differently?
So I think it's a great question. I think it's a huge issue. And the answer is I don't think we do. I think, first of all, when we admit people to medical school, we're bringing people in who are a product of the society in which they live. And I don't think we live in a society where people feel very safe engaging with each other. I think
Right.
there's a lot of lack of trust. And just to be engagement involves a certain amount of vulnerability. And so I think people come to medical
Yes.
school without that. And then medical school, I think, unwittingly, makes it worse. And that's my opinion. This is not research, it's just my opinion and having gone through the process. But I think when you get into medical school, you're you you're on this treadmill where you're just jumping from one multiple choice test to the next. And then once you're in your third and fourth year, you're trying to impress the attending and to present patients well and show you're efficient. And, I think it makes many of us feel chronically insecure. And I think that's so
Yes.
different from being at the bedside of somebody who's suffering and being comfortable just
Yes.
being yourself and being present with them and knowing what that is. And I think the medical education doesn't do service to that. I think in the first 2 years, there's an attempt to. We all take like doctoring courses, but I don't think in my opinion, at least the ones I've seen, a lot of them seem a little bit performative to me. They're teaching you kind of almost a how-to, which is very
Right.
different from figuring out how to be yourself in relationship with people who are your patients and who are coming to you for very difficult and often vulnerable issues.
How would you change medical school, or what do you think that these institutions should be doing to better support medical students in learning these skills?
Well, I may sound a little radical, and again, I have to say this is opinion. This is something that's very hard to study, but I think major changes are needed. I first of all, right now, the gatekeeping course to get into medical school is organic chemistry, and I've actually talked about how I think that's almost a symbol of everything that's wrong with the process. We all know that doctors don't remember their organic chemistry. We all know that it's an incredibly difficult class and that it's often the one that triages the ones who get to move forward and be successful and the ones who don't. And to me, it's such a perverse way of making a decision about who is going to be in a profession where we obviously have to know stuff, we have to be smart, but more than that, we have to be people who can care about people, who can be present for them, and who know where to look things up, know how to find information. But we're not supposed to be walking encyclopedias of minutia. And so I almost feel like organic chemistry is kind of the the metaphor for everything that's wrong. And then what happens is when you get into medical school, it's just more of that, right? You're having to
Yes.
study like crazy for all these tests. I don't think there's a. I'm double board certified, and I don't think there's a first year medical school test I could pass at this point. Um, and so, and so, there's something wrong with that picture, right? And I think, and yet,
Sure.
so people come into medicine with this enormous amount of stuff in their brain, but often feeling somewhat insecure, often feeling like they have to just be efficient, and really not really well prepared for personal engagement with people who are suffering and who need them.
It's interesting. I've often thought that historically we've prepared doctors to be human computers of health information, and that health information has expanded so rapidly. Luckily, now we have computers that doctors can use,
Yes.
right? Right. So we have the bandwidth now to change the model, and people want to connect and need to connect to communicate and to feel better. And the provider needs that connection too, I'm finding.
Absolutely. And I think it's really important that you mention that because we talk about burnout often as something that's driven entirely by externalities. Like, I'm burning out as a physician because of all of the paperwork. I'm burning out because I have to deal with the insurance companies. I'm burning, all of these are, and those are all true. But I think one thing we don't talk enough about is that if you're spending 8 hours a day in an exam room, seeing one patient after another after every 15 minutes, and all you're doing is asking them, and you're not engaging, you're just asking them a series of rote questions so that you can put in orders and write notes, that is going to suck you dry. And I think that is something we don't talk enough about, that if we're not prepared to be present and to find joy in those interactions, then we suffer too.
Yeah. I've most of the physicians that I've ever met got into medicine because they genuinely cared about helping people, and what they wanted to do is heal and help. And that they feel disassociated from their ability to do that with the computer in between them and not having that moment of engagement with the person and really understanding who they are, which is the core of the patient physician relationship.
Yeah, and I do think that, and this is a hard thing to say because it's a somewhat of a critique of my own profession, but I do think that many physicians are unable to engage, that they don't know how, because of the fact that it's their training has been so anathema to that,
Yes.
and it's an it's
Yes.
a it's a painful thing to say, but I say that having listened to thousands of audio recordings, and I think that that's on the profession. The profession has not, I think, undermines developing those personal qualities. To be present for patients requires a certain fearlessness, a willingness to engage, and it also requires very strong boundary clarity. So, if you're with a patient and the patient starts to get very angry at you, for instance, and if you take
Yes.
that personally, rather than understanding that maybe they're angry at you because they have cancer, not because there's anything wrong you've done. But if you can't
They're
see that
frustrated.
and you
Yeah.
react to that negatively and you pull back and you feel defensive, that is going to undermine that engagement. And so I think it's not just the engagement, it's having that boundary clarity, which I think is very challenging to develop. And again, I don't see that that gets developed well during medical training.
And do you think that might be why medical schools haven't encouraged physicians to create that form of engagement, that emotional engagement, because it's not clear how to set those boundaries or wasn't clear? Maybe today we know how and we can teach this.
Yes, I think that if if you if you're not sure that your physicians are going to have boundary clarity, it's better to train them to be performative than to engage. Because if you train
Yes.
them to be performative, which is you give them a set of rules when you walk into the room, this is what you do, this is what you say. If you have to give bad news, this is how you do it, and so forth. If you train that, then that's a kind of paint by numbers approach that will get you a kind of baseline minimum of sort of professionalism. And I do think
Yes.
that is what they do. Um, and it's certainly better than a situation where you don't do that and physicians become defensive or angry or are unable to handle the emotions in a situation when they're vulnerable, and that can be very dysfunctional. So I do
Mm.
think that unless you're very good about talking about and teaching boundary clarity, it's very difficult to safely teach about engagement if you see the connection.
But there's a lot of research now and a lot of education available around emotional intelligence and developing that. As they say, we have the technology, right?
Yes,
We can
yes,
teach this today, and this is
absolutely.
something that people can get good at, right? It's
Absolutely.
possible. So,
I do think that this is absolutely something medical schools could do. Medical schools, again, I don't know all of them, but I haven't seen a medical school that I felt that observed do it well. I think that part of it has to do with the culture of medical education itself. One of the things that I think is really important that I don't see enough of in medical school education is to treat the medical student like a junior colleague. I feel like in my experience, there's a lot of infantilization of medical students where they're treated,
yes.
like high school 10th graders, when they're actually, and many of these people are incredibly impressive. They've had other careers before going to medical school, and yet they're treated in a somewhat infantilized way. And I think that if you if you do that, then you've completely lost the game. And we know that during medical school, there's a lot of research to show this. Students become increasingly demoralized. They enter with actually, on
That's
average,
right.
better mental health than their peers who don't go to medical
Yes.
school, and they end medical school with worse mental health, with burnout, and
Mhm.
even with a certain percentage expressing career regret.
Suicidality. Yes. Yeah. I've seen that. And as a student who went in with a learning disability, do you feel like that was exacerbated? And did you see that exacerbated with others?
I was extremely fortunate in that I had a wonderful mentor who helped me through this process. Simon was
Love
a
that.
family physician. He was generation or two older than me. He actually died in 2020, just before the pandemic. He was almost 90. And during the time when I was going through medical school, Simon, who was actually my godfather, um,
Uh-huh.
very lucky to have had him, was a family
Yeah.
physician. And he was somebody who was able to give me perspective. So when I was struggling in my first year of medical school and I didn't know if I was going to make it through, it was literally just, am I going? I wasn't trying to get an A. I was trying to pass, and I was, it was really hard, and my self-esteem was very poor at the time. And he was able to put it in perspective for me and say, Saul, this is this is not what being a doctor is,
Yeah.
and to help me through that. And this doesn't reflect the kind of doctor you will become, and to just really give me that. But if I hadn't had that, I think things would have been, I don't know if I would have made it.
I've heard this from other physicians and nurses and PAs and so forth that their mentor was so important to their confidence building, to their knowing how to relate well to people, how to develop those boundaries. What are your thoughts on mentorship in general, and are we offering them enough, and what should we be doing with them?
Yeah. I think, first of all, if you have the opportunity to be a mentor to somebody, it's a really special opportunity. And the most important thing, in my view, is to have no other agenda other than their personal and professional growth. And that requires meeting them where they are. It requires understanding, for instance, if this is a person who just needs some emotional support or whether it's a person who needs some good advice. I mean, or maybe a combination of those two things. But you have to be
Sounding board.
yeah, you
Yeah.
have to be so careful because that person is often so vulnerable. Often they're struggling emotionally with the situation they're in, and so you have to be so careful to protect their ego, but also to be able to guide them and to ultimately create an environment where they feel safe and they trust you. They trust you that you have no other agenda than to be helpful to them. And the other thing I would say is that if you're looking for a mentor, don't rely just on one mentor. You can benefit from multiple mentors at a time.
Yes. Yes. I think that's right. How do you think we can foster more mentorships, especially in medical school and beyond?
I think that uh, if you're looking for a mentor, if you're a medical student or a resident, um, you look for people who you feel like you can trust, and people who are looking to be mentors um, should be people who, again, are trustworthy. And by trustworthy, I mean something that has an emotional dimension to it as well, that person is a safe space. And I think in medical education and in the world of medicine, there's a shortage of this. There's a shortage of people who feel safe. And there's a short and without that, you don't get good mentors. I
Yes.
don't think, I mean, in some cases, it's nice to have a mentor with great content expertise. So, for example, if you're pursuing a research career, you want a mentor who
Sure.
knows a lot about research. And of course, that is going to be, and if you want to be a cardiologist, you want a mentor who's probably a good cardiologist and knows so there's certainly the content dimension of mentorship. I think that's pretty plentiful. You can find lots of people who are experts, who know a lot
Yeah.
about how to get into something and how to proceed. But I'm taking that as a given. We have a lot of that. But what I don't think we have enough of are people who have that. And in addition, are safe and are available and are generous with themselves.
I love that. And these are all things people can get good at as well
Yes,
if they want to be,
if they
right?
want to be.
And right. I think at the Medical Society of Virginia, and I know at others around the country, we teach this sort of work in our leadership seminars and so forth, and develop a lot of these soft skills so that people can offer their mentorship to others. I would really encourage people to seek this out and seek to be one. You get as much as you
You
give,
sure do.
frankly, in these relationships. In your book, you argue, I would say, that joy in medicine comes from meaningful engagement like this. What does joy look like in your own practice?
I find that the older I get, and I'm not young anymore, I've been doing this for a long time,
Yes,
the
you
more I
are.
enjoy encounters with patients. And I find I actually work in several different settings. As you know, I'm a pediatrician, I'm also an internist. And in addition, I also care for veterans, which I've been doing for many years. And so
Yeah.
if I walk into, for example, on Monday mornings, I staff I work in a track in the emergency department at the VA where we see sort of acute care issues that are not like all out emergencies, people coming in with, back injury, things like that. And a lot of our veterans in Chicago are low income, have low health literacy. Many of them have post traumatic stress disorder. They have had a tough life. And when I walk into a room to see a patient who comes from a background like that, where they have struggled, where they've been marginalized, where they don't necessarily communicate that well because they have low health literacy, I used to find that frustrating, and I genuinely find it now to be the highest privilege. I absolutely love
Oh,
walking in there and just finding out how that person is doing, what's going on with their aches and pains, and just connecting with them. And I can't explain why. When I was much younger, I found that sort of irritating and frustrating, and now I just love it. Um, that's all I can say.
maybe that's the wisdom of age and experience.
It, perhaps, but it's I first of all, the folks I meet with have very different lives than I do, and some of them are experiencing homelessness. I mean, these are people who have had it really tough, and my heart goes out to them. I feel like when the dice were rolled, I got the good number and they got the bad number, right? You don't
Yeah.
know our where we are in life is just it's just a roll of the dice that begins at birth, And when I walk in and I see folks who have had it really tough, who are struggling, are often incredibly resilient. It could be an old guy who's got on a motor scooter, who lives alone. I have no idea how he manages. And I start asking him questions, and I hear all of the tricks of the trade of how he gets by from day to day, and it's very inspiring to me, and it's just fun to talk to people who have a very different way. And again, the privilege sense comes from the fact that these are people who've had it really rough, who've had it really tough, and the opportunity to try to just learn a little bit about that and be helpful to them feels much more special to me now than it did early in my career.
Yeah, sense of gratitude, but also perspective, very helpful. And frankly, respect, right? Respect, it sounds like. Well, I have an important last question for you, which is what advice would you give? I want to say to a young doctor, but frankly, maybe even any doctor who feels disillusioned or disconnected from their patients. What would you invite them to do or encourage them to do?
So I would say there are two pieces of advice. One is to look outward, and the other is to look inward. So the outward piece is be realistic about whether you're in a toxic environment. I do think there are toxic work environments where no matter who you are as a person, it's not going to be functional. And I think that is a reality. And hopefully not too many listeners are in a toxic environment. But if you are in one, then you do have to find a different place. And I do want to be realistic about that. I think it's naive to think that we can just enjoy life and practice and not be burned out in any setting. It's just not true.
Right.
And then of course, if you're in a situation that is not tenable but maybe fixable, then maybe you can fix it, right? Maybe there are ways in which you can advocate so that you're not working under conditions that are just sure to produce burnout. But if you've done those things and you are in a basically reasonable environment, then I do also think it's important to think about ways in which you are finding joy or not finding joy in medicine. But we have to be honest with ourselves when we're with patients who, quote, irritate us. Why is that? Are there ways in which we can just find joy in the fact that that person is not intending to irritate us? They're just going through life, and they're struggling in their own way, and we're experiencing some of that, but we're here to look out for their well-being, whether they appreciate it or not, and to find satisfaction in knowing that maybe something about that interaction has been beneficial to them, even if they don't show gratitude. So I would say those are the two sides of the coin that I think are useful to think about.
Those are very practical, and I really do like the reflective piece. There's usually something under that itch, isn't there? And there's work to be done no matter where we are in life. I love that. Well, spending time with you, I've learned a lot. And I actually took a couple of nice hints out of this. But thank you for taking the time. Is there anything else you want to share?
No,
with-
Melina, these were great questions, and I really
uh,
appreciate the opportunity to chat with you.
Dr. Winter, we were very grateful to have you with us. And I know people are going to love this episode. Thank you for being here.
Wonderful.